Pediatric neurologic disease. Cerebral palsy is a group of non-hereditary, non-progressive disorders of muscle tone and is the most common movement disorder in children. It often results from prenatal, perinatal, or neonatal neurologic insult, but in most cases stems from an unknown cause. Risk factors of cerebral palsy include low birth weight, intrauterine exposure to maternal infection, prematurity, perinatal asphyxia, trauma, brain malformation, and neonatal cerebral hemorrhage. Pregnant patients at risk for preterm birth are given intravenous magnesium sulfate to decrease the incidence of cerebral palsy. Categories include pyramidal, spastic, extrapyramidal, dyskinetic, and ataxic types. The pyramidal or spastic type results from damage to the motor cortex and presents with spastic paresis of any or all limbs, accounting for 75% of cases. Intellectual disabilities are also present in up to 90% of cases. The extrapyramidal or dyskinetic type results from damage to extrapyramidal tracts. Subtypes include chorioathetoid and dystonic, characterized by uncontrollable jerking, writhing, or posturing. Abnormal movements worsen with stress and disappear during sleep. The ataxic type results from damage to the cerebellum and often presents with lack of body coordination and hypotonia. Cerebral palsy may be associated with seizure disorders, behavioral disorders, hearing or vision impairment, learning disabilities, speech deficits, gastrointestinal disorders, or other associated complications of prematurity. Delayed achievement of gross motor and fine motor developmental milestones is common. Affected limbs may show hyperreflexia, pathologic reflexes such as Babinski, increased tone or contractures, weakness, and underdevelopment. Definite hand preference before 1 year of age is a red flag. Toe walking and scissor gait are common findings. Hip dislocations and scoliosis may also be seen. The most common presenting symptom of cerebral palsy is delayed motor development. Diagnosis is often clinical, but imaging can be used to determine the underlying cause of cerebral palsy in some cases. Ultrasonography may be useful in infants to identify intracranial hemorrhage or structural malformations. Magnetic resonance imaging can be diagnostic. Electroencephalography may be useful in patients with suspected seizures. A full evaluation of hearing, vision, and developmental milestones, especially motor milestones, should be performed if cerebral palsy is suspected. There is no cure for cerebral palsy, and multidisciplinary treatment is required. Special education, physical therapy, braces, and surgical release of contractures may help improve function and quality of life. Spasticity can be treated with baclofen, diazepam, or dantrolene. Botulinum toxin can be helpful for localized spasticity. Baclofen pumps and posterior rhizotomy, which involves nerve destruction for pain relief, may be used to alleviate severe contractures. Febrile seizures usually occur in children between 6 months and 5 years of age who have no evidence of intracranial infection or other causes. Risk factors include a rapid increase in temperature and a history of febrile seizures in a close relative. Febrile seizures recur in approximately 1 in 3 patients. Seizures usually occur during the onset of fever and may be the first sign of an underlying illness such as otitis media or roseola. They are classified as simple or complex. A simple febrile seizure is a short, less than 15-minute, generalized tonic-clonic seizure with 1 episode in a 24-hour period and a return to neurologic baseline shortly afterward. A high fever greater than 39 degrees Celsius or 102.2 degrees Fahrenheit within hours of the seizure is typical. A complex febrile seizure lasts more than 15 minutes, may be focal, or involves multiple seizures in a 24-hour period, where there is no return to neurologic baseline. A low-grade fever for several days before seizure onset may be present. Febrile status epilepticus refers to prolonged continuous seizures lasting 30 minutes or intermittent seizures without return to baseline in between. Diagnosis is often clinical, with exclusion of central nervous system abnormalities, inflammation, or metabolic dysfunction that can account for the seizure. The focus should be on finding the source of infection. Lumbar puncture and cerebrospinal fluid studies are indicated if there are concerns for clinical signs of central nervous system infection, such as altered consciousness, meningismus, or a tense or bulging anterior fontanelle after ruling out increased intracranial pressure. No workup is necessary for first-time simple febrile seizures, and no laboratory studies are needed if consistent with febrile seizures. Infants younger than 6 months of age require a sepsis workup, including a complete blood count, urinalysis, and blood, urine, and cerebrospinal fluid culture. For atypical presentations, electrolytes, serum glucose, blood cultures, urinalysis, and complete blood count with differential and other studies as applicable should be obtained. Only perform a lumbar puncture if central nervous system infection is suspected in a patient with a febrile seizure. Keep in mind that if a patient is on antibiotics, it can mask symptoms of an infection. First-time febrile seizures can be managed with observation and parental counseling. Seizures lasting more than 5 minutes should be treated with anticonvulsant medications such as benzodiazepines. Febrile status epilepticus can be treated with fosphenytoin. The patient can be treated with antipyretics such as acetaminophen, but aspirin should be avoided due to the risk of Reye's syndrome, acute liver failure, and encephalopathy, and any underlying illness should be addressed. Note that antipyretic therapy does not decrease the recurrence of febrile seizures. For complex seizures, a thorough neurologic evaluation should be conducted, including electroencephalography and magnetic resonance imaging. Chronic anticonvulsant therapy, such as diazepam or phenobarbital, is only needed if abnormalities are found and is usually not necessary. The risk for recurrence is about 30 to 35% and is highest within 1 year of the initial episode. For simple febrile seizures, there is no increased risk for developmental abnormalities and only a slight association with this being an early manifestation of an underlying epilepsy. Risk factor for the development of epilepsy include complex febrile seizures, with approximately 10% risk, a positive family history of epilepsy, an abnormal neurologic examination, and developmental delay. Simple febrile seizures do not cause brain damage, do not increase the risk for developmental abnormalities, recur in about 30 to 35% of cases, and have only a slight association with being an early manifestation of underlying epilepsy. Infantile hypotonia is the lack of tone or resistance of muscle movement. It differs from weakness, which is the decrease in active muscle contraction. Common causes of infantile hypotonia include botulism, spinal muscular atrophy, and myotonic dystrophy type 1. Botulism is caused by the Clostridium botulinum toxin, which prevents presynaptic release of acetylcholine. The spores are found in honey or soil. Constipation is sometimes the first presenting sign, followed by symmetric descending paralysis. It typically occurs before 12 months of age. Treatment includes supportive care and administration of botulism immunoglobulin. Spinal muscular atrophy is caused by a mutation in the SMN1 gene. The infantile type, also known as type 1 or Verdnig-Hoffmann disease, leads to anterior horn cell and motor nuclei degeneration. It presents with progressive muscle weakness and atrophy, tongue fasciculations, and symmetric proximal muscle weakness greater in the lower than the upper extremities. There is no cure, and treatment is supportive. Myotonic dystrophy type 1 is a trinucleotide repeat disorder with a CTG repeat on the DMPK gene. It is an autosomal dominant disorder that is commonly inherited through the mother. It causes increasing loss of muscle tone and weakness, especially in the facial muscles, and can present in infancy as hypotonia. The most common onset is between the 20s and 40s. It is associated with mental retardation, cataracts, and arrhythmias. Treatment is supportive. Common brain neoplasms in children include pilocytic astrocytoma, medulloblastoma, ependymoma, craniopharyngioma, and pinealoma. Pilocytic astrocytoma is a generally benign, well-circumscribed tumor of astrocyte origin that stains for glial fibrillary acidic protein, GFAP. It is a posterior fossa or infratentorial tumor and is the most common central nervous system tumor in children. It presents with drowsiness, headache, ataxia, nausea, vomiting, and cranial neuropathy. It is slow-growing with a protracted course and favorable prognosis. Histologically, it shows bipolar neoplastic cells with hair-like projections, microcysts, and Rosenthal fibers, which are eosinophilic corkscrew fibers. Grossly, it appears as a cystic and solid mass. Treatment involves surgical resection if possible, followed by radiation. Medulloblastoma is a primitive neuroectodermal tumor, PNET, of the posterior fossa or infratentorial region. It arises from the fourth ventricle or cerebellar vermis. Histologically, it shows homerite rosettes and small blue cells that are synaptophysin positive. It is highly malignant but radiosensitive and may seed the subarachnoid space or spread as drop metastases to the spinal cord. It may cause obstructive hydrocephalus by compressing the fourth ventricle, leading to headaches, papilledema, and vomiting. Truncal ataxia occurs due to involvement of the cerebellar vermis. Treatment includes surgical resection coupled with radiation and chemotherapy. Ependymoma is a tumor of ependymal cell origin, most commonly found in the fourth ventricle, but may also present as primary spinal cord tumors. It shows characteristic peravascular pseudorossettes and rod-shaped blepharoplasts, or basal ciliary bodies, found near the nucleus. It causes obstructive hydrocephalus by compressing the fourth ventricle, leading to headaches, papilledema, and vomiting. Myelopathy and radiculopathy are possible presenting symptoms when the spinal cord is involved. Treatment includes surgical resection followed by radiation or chemotherapy. Craniopharyngioma is the most common suprasellar tumor in children. Calcification is common and helps distinguish it from pituitary adenoma. It is derived from remnants of Rathke's pouch, which is ectodermal in origin, and cholesterol crystals are found in motor oil, like fluid within the tumor. It is benign, but commonly causes bitemporal hemianopsia due to compression of the optic chiasm and is associated with a high recurrence rate. Treatment involves surgical resection. Pinealoma is a germ cell tumor of the pineal gland, similar to other germ cell tumors such as testicular seminoma. It is a mass arising in the third ventricle and is malignant. It can cause Parnose syndrome due to compression of the tectum, leading to vertical gaze palsy. It may also cause obstructive hydrocephalus by compression of the cerebral aqueduct and precocious puberty in males due to human chorionic gonadotropin, HCG, production. Treatment includes radiation therapy with or without chemotherapy. Spinal dysraphism is a type of neural tube defect caused by improper closure of the neural tube, leading to a potentially exposed spine or spinal cord. An important risk factor is folate deficiency during pregnancy. Patients present with varying clinical features depending on the type of spinal dysraphism. Closed spinal dysraphism includes spina bifida occulta, the most common type, which results from a defect in the vertebrae with intact meninges and spinal cord. Patients are usually asymptomatic but may have a tuft of hair or a small dimple at the level of the defect. Open spinal dysraphism includes meningocele, in which the meninges protrude through the vertebral defect while the spinal cord remains undamaged, and myelomeningocele, the most severe form, where a portion of the spinal cord herniates through the vertebral defect. Diagnosis of open spinal dysraphism is often made prenatally by detecting elevated alpha-fetoprotein, AFP, levels in the maternal serum quad screen. Ultrasound is then used to confirm the diagnosis and rule out other causes of elevated AFP, such as multifetal gestation. Treatment for closed spinal dysraphism involves observation, as many patients remain asymptomatic. Open spinal dysraphism, being more severe, requires surgical intervention within the first 3 days after birth to minimize the risk of infection. Long-term management involves a multidisciplinary approach to optimize neuromuscular function and improve quality of life. Breath-holding spells are non-epileptic paroxysmal episodes that usually occur between 6 months and 6 years of age. These episodes involve brief periods when young children stop breathing for up to 1 minute, often leading to loss of consciousness. The spells are typically triggered by emotions such as anger, frustration, pain, or fear, and occur as a reflex rather than a voluntary act. There is a strong association between breath-holding spells and certain forms of anemia, particularly iron deficiency anemia, and a family history of such spells is also common. Breath-holding spells are triggered by emotional stress and may result in loss of consciousness or cyanosis. Although they can be alarming for parents, these episodes are benign and not related to cardiac disease. They usually resolve by around 5 years of age. The cyanotic variant is the most common form. It is generally preceded by an upsetting event, such as a reprimand or temper tantrum. The child typically cries, then experiences forced apnea followed by loss of tone and consciousness, with marked cyanosis. The pallid variant, on the other hand, often follows a minor trauma to the head or upper body. The child becomes pale and diaphoretic, loses tone, and briefly loses consciousness. Diagnosis is clinical and based on a detailed history to differentiate it from seizure activity. A workup for anemia, including hemoglobin and ferritin levels, is recommended. The prognosis is excellent, and most children outgrow the condition completely by 8 years of age. Treatment focuses on correcting any iron deficiency anemia, as this can reduce the frequency of episodes. Antiepileptic medications are not recommended, and the spells typically resolve spontaneously over time. Rett syndrome is a neurodevelopmental disorder caused by a mutation in the mek2 gene on the X chromosome and is most commonly sporadic. It occurs almost exclusively in females, as affected males usually die shortly after birth. The manifestations of Rett syndrome typically begin between 6 and 18 months of age, following an initial period of normal growth and development. The earliest sign is a deceleration in head growth. As the condition progresses, affected children gradually lose communication abilities, fine motor skills, and intellectual function. A distinctive hallmark of Rett syndrome is the appearance of stereotypical hand movements, such as constant grasping of hair or clothing, along with episodes of inconsolable irritability. Additional features may include loss of spoken language, motor dysfunction, scoliosis, growth failure, beginning with reduced head circumference followed by decreased height and weight, epilepsy, decreased bone mineral density, cardiac and autonomic dysfunction, sleep disturbances, and abnormal breathing patterns during wakefulness. Diagnosis is based on clinical suspicion and confirmed by DNA analysis showing a mutation in the mek2 gene. Treatment is primarily supportive, as there are currently no disease-modifying therapies. Management involves a multidisciplinary approach, including physical, occupational, and communication therapy. Regular monitoring of growth, nutrition, cardiac function, sleep, and neurological status is essential for comprehensive care. Chiari malformations are congenital defects resulting from underdevelopment of the posterior fossa, leading to structural abnormalities at the base of the brain. There are 2 main types, Chiari I and Chiari II. Chiari I malformation is characterized by herniation of the cerebellar tonsils through the foramen magnum. It typically presents later in childhood or adolescence with occipital headaches and cerebellar symptoms such as ataxia and dizziness. The headaches are often worsened by activities that increase intracranial pressure, such as coughing or performing the Valsalva maneuver. Chiari I is commonly associated with syringomyelia. Chiari II malformation involves herniation of the cerebellar tonsils, vermis, and medulla through the foramen magnum. It presents at birth with symptoms related to brainstem compression, including apnea, stridor, and dysphagia. Non-communicating hydrocephalus may develop due to aqueductal stenosis. Chiari-2 malformation is classically associated with lumbosacral myelomeningocele, which can result in lower limb motor weakness and sensory deficits. Benign familial microcephaly and macrocephaly are variations in head size that occur in otherwise normal children. Microcephaly is defined as a head circumference more than 2 standard deviations below the mean, while macrocephaly is defined as more than 2 standard deviations above the mean. These findings are typically familial, diagnosed in healthy children with a parent who has a similarly sized head. Developmental milestones and physical examinations are normal, with no associated syndromic features.